Welcome to today's Explainer, where we're going to put on our medical detective hats. We're tackling a classic clinical mystery, where a single collection of fluid actually holds all the life-saving answers. You see, ascites isn't just a random accumulation of fluid. It's a profound disruption of the body's internal balancing act. And really understanding it? Well, that means breaking it down from its absolute first principles.
Okay, let's jump right into this by picturing two patients in front of you. Both have these swollen, fluid-filled abdominals. Patient A has obvious spider naevi on their skin, a yellowish tint of jaundice, and severe pitting swelling in their legs. Patient B, on the other hand, looks otherwise pretty well, but they've been quietly losing weight and, crucially, absolutely no leg swelling. Now, your gut instinct might scream that they have the exact same problem, but these two patients likely have entirely different underlying diseases. And the secret to telling them apart is actually written directly into the chemistry of the fluid itself.
Here's our roadmap for today. We'll cover a tale of two patients, pressure versus peritoneal disease, SAAG as the deciding number, the missing leg edema trap, diagnosing SPP before it kills, and finally, management and modern trade-offs. Let's get right into it. Section 1, A Tale of Two Patients. The clinical illusion of the swollen abdomen. Ascites is essentially your abdomen's flashing red alarm. It's signaling that fluid dynamics somewhere in the body have completely broken down. But what's so fascinating here is that the exact way those dynamics failed isn't some guessing game. It's written right there in the fluid, as long as you know exactly what you're looking for. Section 2. Pressure versus peritoneal disease. The physics of the crime scene. Normally, fluid moves back and forth between blood vessels and the peritoneal cavity based on a really delicate balance of pressures. And this fundamental branch point is where the entire pathophysiology splits. Ascites happens when this balance breaks in one of two fundamentally different ways. Either it's pressure-driven, meaning high pressure within the portal venous system is literally mechanically forcing fluid out through engorged vessels. Or it's disease-driven, where the peritoneal itself becomes infiltrated by a tumor or infected by something like tuberculosis that directly increases capillary permeability and leaks fluid and protein, totally regardless of portal pressure. Section 3. SAAG, the deciding number, the smoking gun laboratory test. So how do we figure out which one we're dealing with? We use the serum ascites albumin gradient, better known as the SAAG. You calculate this just by subtracting the acidic fluid albumin level from the serum albumin level. And this brilliant little calculation gives us a direct measurement of the pressure difference between the blood vessels and the peritoneal cavity. And it all comes down to one absolutely crucial number, 1.1 grams per deciliter. That single number is the threshold that pivots your entire diagnostic pathway. Here is exactly how that number splits our differential. A SAAG of 1.1 or greater tells us that portal hypertension is driving the bus. That high portal pressure is forcing fluid across the membrane, but leaving the bulky albumin relatively behind, which creates a wide gradient. This points us straight toward conditions like cirrhosis, congestive heart failure, Bucchiari syndrome, or constrictive pericarditis. On the flip side, a SAAG strictly below 1.1 points to a leaky, diseased peritoneum where protein and fluid are moving together, narrowing that gradient. So we're looking away from portal hypertension and toward things like malignancy, tuberculosis, nephrotic syndrome, or pancreatic ascites. Section 4. The missing leg edema trap. Reading bedside clues before the labs return. Now, even before that SAAG lab result hits your chart, the bedside picture holds massive clues. Cirrhosis produces both portal hypertension and systemic hypoalbuminemia at the exact same time. This means fluid is going to accumulate in both the peritoneum and dependent tissues, giving you that classic peripheral leg edema. Malignancy, or TB, however, is typically a localized peritoneal process, without that systemic drop in oncotic pressure. Because of this, ascites without leg edema is a massive bedside red flag for a non-cirrhotic cause. It perfectly explains the logic that separates those two patients we talked about at the very beginning. And when you're actually at the bedside examining your patient, you really need to know what your hands can reliably detect. Flank dullness is your most sensitive sign, present in about 90% of cases. But you need at least 500 milliliters of fluid in there to detect it. You then use shifting dullness to confirm that flank dullness. But what if the fluid volume is way smaller?
Well, for volumes as little as 120 milliliters, the puddle sign can technically detect fluid that flank dullness would miss. Though, just a quick aside, we all know this carries genuinely low sensitivity in everyday practice.
Section 5. Diagnosing SBP before it kills. The ticking time bomb of ascites. Spontaneous bacterial peritonitis, or SBP, is the complication that demands your absolute highest index of suspicion, simply because it is incredibly dangerous and fast-moving. It happens through this stealthy mechanism called bacterial translocation. Gut bacteria literally cross an increasingly permeable cirrhotic altered intestinal wall directly into ascitic fluid, which has unfortunately lost much of its normal antibacterial defense capacity.
To catch this ticking time bomb, you need to memorize one critical diagnostic threshold: an acetic fluid polymorphonuclear leukocyte count, so your PMN neutrophil count, strictly above 250 cells per cubic millimeter. The rules here are incredibly strict for a reason. You must perform a diagnostic paracentesis on all cirrhotic patients admitted to the hospital with ascites. Period. If that PMN count comes back over 250, you've got your diagnosis. And crucially, negative cultures absolutely do not rule out SBP. Culture-negative SBP happens in up to half of cases, so do not wait. You treat immediately with a third-generation cephalosporin, typically intravenous cefotaxium. Plus, you absolutely have to give IV albumin alongside those antibiotics. This has been definitively shown to meaningfully reduce mortality by protecting the patient's renal function during that huge septic insult.
Section 6. Management and modern trade-offs, from salt restriction to transplant.
Now let's talk long-term management. Ascites follows a very logical, stepwise escalation. Step 1 is basic dietary sodium restriction, typically aiming for 80 to 120 millimoles per day. Step 2 introduces a combo of spironolactone and furosemide, carefully dosed to maintain normal potassium balance while maximizing fluid output. Step 3, for large volume or refractory ascites, means moving to therapeutic paracentesis with albumin replacement. And finally, Step 4 turns to mechanical solutions, like a TIPS procedure to manually reduce that portal pressure gradient, or ultimately evaluating for a liver transplantation for genuinely refractory disease.
But you know what's just as important as what you do? Knowing what you absolutely must not do. There is a strict prescribing caution for these patients. You have to strictly avoid NSAIDs, which can quickly precipitate renal failure and hyponatremia. You also need to dodge ACE inhibitors, alpha blockers, and aminoglycosides. These can easily cause hypotension and renal impairment in a patient whose circulation is already hanging on by a hemodynamic thread.
So, what about keeping SBP from coming back? Prophylaxis is indicated for any patient who has recovered from a prior SBP episode or if their acidic fluid protein is notably low, specifically below 15 grams per liter. Historically, the gold standard agent was norfloxacin, but since norfloxacin is no longer available in the US, our modern substitutes are ciprofloxacin or trimethoprim sulfamethoxazole. But this leads us right into a really fascinating current medical debate. Does indefinite secondary prophylaxis actually carry too high a cost?
Medicine is literally always evolving, right? We have this cutting-edge 2024 cohort data from Sylvie and colleagues that specifically questions whether secondary SVP prophylaxis genuinely reduces recurrence as reliably as we always just assumed it did. Furthermore, the data actually shows it's associated with a higher rate of non-SVP infections, particularly UTIs, likely because we're continuously disrupting normal gut flora. This exposes the real-world trade-offs of indefinite antibiotics, reminding us we need to periodically reassess our patients rather than just blindly treating prophylaxis as a permanent, unquestioned default. So we've walked through the two totally distinct driving forces of ascites: the pure diagnostic power of the SAAG, the silent and deadly threat of SBP, and the escalating steps of management. The next time you're at the bedside and you feel that shifting dullness in a distended abdomen, don't just stop at the word ascites. I want to leave you with a challenge. Will you remember to step back, check for that missing leg edema, look closely for the stigmata of liver disease, and pull the SAAG to let the fluid itself reveal the true diagnosis? By applying these first principles, you transform from someone just observing a symptom into someone solving a complex medical mystery. Thanks for joining me on this explainer. Keep questioning, keep learning, and I'll catch you on the next one.